Hello and welcome to IdeaFest 2024 and our panel discussion on how artificial intelligence is changing healthcare. I'm Joel Martin and I'm an operating partner at HealthX Ventures. We're an early stage venture capital firm based in Madison, Wisconsin, and investing in companies making healthcare safer, more efficient, and more affordable. And one way we're doing that is with artificial intelligence. It's already changing lives and businesses across the world, and healthcare is not far behind. Today, I'm joined by a great panel of experts from different parts of the industry to discuss how AI is impacting healthcare today and how it might change things in the future. I'd love to introduce the panel here. First of all, David Butler is a physician and informaticist who's been leading teams and guiding organizations through digital health adoption and transformation for over 20 years. He served as the Chief Medical Information Officer at NYC Health and Hospitals and Guthrie Health, along with many other healthcare organizations around the country. He served as a longtime advisor to Epic Systems here in Madison and is currently the CEO of healthcare advisory firm HealthX Health. Bob Lindner is an astrophysicist and data scientist who's been writing, publishing, and building in the field of artificial intelligence for over 15 years. As a postdoctoral researcher at UW-Madison, Bob invented GaussPy, an AI program still used by NASA and 40 other research facilities around the globe. He currently serves as founder and chief technology officer at Veda Data Solutions, a provider of AI tools for provider data management used by half of the 10 largest health insurance companies in America. And finally, Brad Taylor is an engineer who's been working on the cutting edge of healthcare research and informatics for over 15 years. He's the Chief Research Informatics Officer at the Medical College of Wisconsin, where he and his team work with clinicians, staff, and faculty across multiple organizations to integrate research into clinical workflows. Thank you all for joining us. And I'd like to start with talking about past technology revolutions or anticipated revolutions. David, let's start with you. You've been working on EHR adoption for 20 years or more. And that has been, and certainly was back 20 years ago, put out there as something everyone believed would kind of revolutionize things. Was the perspective on EHR adoption 15 to 20 years ago similar to AI today? And has it been as revolutionary as we expected? How is that looking back at it from today?
I think that's a solid question, Joel. I think that when I started doing this was actually in residency. So I think my generation of physicians, we're called the digital native docs, kind of. Where when we started med school, they gave us an email address. We didn't know what the @ sign was, right? They said you got to put something after the @ sign. So this was that time, okay? And this was around 95. The internet's hot, 3 or 4 more years, Napster starts getting hot. We're in residency, the new residents, kind of the traditional docs, are our teachers and things like that. So, and I think we were one of the first technology-enabled classes of physicians to come through, where we got a chance to experience the old guard, meaning paper. Paper is everywhere, right? I saw a quote that says, "Your hospital will be paperless when your restroom is." This is how crazy it was in early 2000 when we were really trying to go from we were going from paper to pixels, Joel. And so during that time, though, I think it was more certain systems. Like I joined Geisinger in early 03 as a doctor. I didn't know anything about these EHRs, and so I landed there in the middle of Pennsylvania. Geisinger had done something way before it was cool. No High Tech Act, no meaningful use, none of these motivating things. And they had bought this little system out of Wisconsin called Epic, and it was terrible. I mean, like, it was really costing me a lot of time, And so I was complaining and sending screenshots to whoever would listen and say, "Help, help, help." But the administration who purchased it said, "No, it's better for safety. We can get better data and things like that." But it was like, version 1.0, right? So it was really tough during that time. And that's what kind of threw a lot of my generation docs antennas up to say, what can we do to help focus on the patient and not the technology, right? So back then it was more of a mandate. This technology was mandated. We had to go from paper to pixels. You had to get off some of the paper so that the patient can then be a part of their care. we had to be able to measure it, right? So my generation was about, let's get this system in so that we can start measuring this randomness that docs were doing and nurses and healthcare in general, right? And then you start coming out with the big papers coming out by Don Berwick to Error is Human, things like that, where they start saying like, oh, we're hurting over, I think it was 90,000 patients a year that died of unintended medical consequences due to lack of automation in healthcare, right? And so start paying attention to that, start making actions to that. So this was more like what we saw was a force at the time. We were forced to get on these things. They were getting turned on. This is the vibe of docs, frontline clinical docs at the time. And so we were having to turn it on. Big systems were purchasing it because they could get it for really discounted prices with the meaningful use and high tech that, right? Great, let's go there. And now, so I think that that's where we've been, and now we're still feeling the forced adoption. You know, I call it a forced adoption of this technology by your frontline docs, nurses, pharmacists, ancillary staff, and all that. So that's where we are now. So there's still this reluctancy due to the user experience. User interface may not be as optimal, not like the gaming experience, right? And I have to always have to share with my non-physicians, non-folks that are in healthcare how it works. For example, when you buy an Xbox, right? It comes out of the box, very complicated, a lot of D-pads and buttons, complicated gameplay on the screen. 16 different folks are playing with you, but it's seamless. It's made of ones and zeros. And the question is, what happened over here on the EHR? You have neurosurgeons over here that can't figure that EHR out sometimes, right? And so that's where we are now. So I think that what's happening is that AI, though, compared to that, right? That's where we came from. But now AI feels more like the cavalry, right? I felt like the EMR were ground troops, right? And it was hard to get in. That was some tough bush, whatever. I'm a World War II guy. And so now, not two, but cavalry didn't do much. But now AI is going to come in and they can really cut through some of these administrative processes, some of the administrivia we call this documenting. I think I saw something online. Someone said that, well, doctors have to be up 2 hours at night documenting, finishing documentation, things like that from the EHR related visits that day, right? And it's really more appropriate to describe it as doctors must have 20 to 25 meetings a day to make the salary that they make in the organizations that they belong to. And they must have meeting notes, agendas, and minutes to those notes at all 25 visits. So the payer and the patient and the lawyers and everyone else can see what we did. That's where we are now. And I think that's where AI can really come in and help us be doctors again and not digital transcription. So that's my thought. That's my thoughts on the whole thing. Yeah, sorry for a long one.
So the EHR was sort of the for everyone else, and now the AI might be coming in to help the doctors.
Please, I mean, we need it. I'm sure I speak for a lot of docs out there.
So Brad, you were one of those, at least theoretically, beneficiaries of the EHR information, you and your teams. Looking back at that period, whether it's about EHRs or other technology you've used, how has technology changed for informatics and research over that time? Is it more, trying to look back to 2009, is it more different than you expected, or is it more the same than you expected? What's the magnitude of change that you expected versus what's actually happened?
There's definitely some differences. So just to be clear, I spent about 10 years in consulting prior to joining MCW. So I've been with MCW for about 15 years, so about 25 years worth of experience in this space. And when I originally joined MCW, I was part of the Human and Molecular Genetics Center. So that's the HMGC, where we were building tertiary applications for whole genome and whole exome sequencing. So we were doing a lot of quote unquote AI at that point in time, but it was kind of traditional rule-based expert systems, logistic regression, and more recently, more convolutional networks, if you will. But thinking about it from a healthcare delivery perspective, AI has had a significant impact on a variety of different domains within the healthcare space. If we think about pathology and looking at slides, AI has helped to accelerate outcomes for the pathologist and looking at those slides and even picking things up that a human might not have seen. Same thing in radiology. So we've seen tremendous impacts in those spaces. And now we're seeing Gen AI really starting to have an impact for healthcare delivery. So as Dr. Butler had described, it's there to facilitate the clinicians, the physicians in front of patients to accelerate those care delivery pathways. But we're also seeing this taking place in the research space as well. My primary focus over the last 15 years has really been in the research space. So doing whole genome, whole exome sequencing, looking at better therapeutic pathways for our patients, looking at clinical trials, things along those lines. The last mile has always been, and I think it will continue to be, I think there's still some effort to be done in this space, in NLP, so natural language processing. So all those notes, Dr. Butler, that you're putting into the EMR for your patients, we now need to extract meaningful information out of those to do research on those patients, to identify better pathways for treatments and so on and so forth. NLP is kind of a key. We've been doing regex for years, but large language models have really turned the industry on its head and has really started to accelerate some pathways for learning about what's going on in a patient's journey within a health system.
Great. And so maybe just sort of continuing on that path, that NLP isn't new, but have there been those kind of natural language processing technologies that you've experimented with previously that have not lived up in a way that you expect the current generation of tools with artificial intelligence to do better? And what do you sort of learn from that experience?
I think historically NLP, again, using things like regex, is very time intensive to create those concept extractions. So the amount of effort that needs to go into traditional NLP significantly outweighs what a large language model or new Gen AI techniques might be able to handle. So I see the acceleration taking place. Traditionally, it worked, but not as well and not as quickly as we would like it to have been. And that's where we're really seeing the impact of Gen AI in today's market space.
Right. And David, what about from the ways that EHRs fell short? I mean, we already touched a little bit on that. It was for other parts of the healthcare delivery system than the physicians. What other lessons would you take from the EHR experience as we or others watching this think about implementing new technology systems and especially AI?
Oh, yeah, no, I think the number one thing, Joel, that I will always hit on, come back to every time is there was somehow a miss in the early days of the CHR implementation. Change management, such a soft term. I don't quite like that term either, okay? Because it's hard to prove to execs, administrators that are paying for this EHR technology. It's easy for them to see the tech and turn it on, but it's hard for them to see, like, why do we need to invest time in physicians to touch it, feel it, understand it before we just turn it on? Seems like we should just turn it on, right? And so the lack of change management, or I call it peopleware, man. Software is everywhere, but what's missing is really a focus on the people that's going to touch this stuff, right? You have busy docs seeing 25 patients to 30 patients a day, right? And then right now, I mean, literally in the next month, let's say one of the bigger healthcare systems they're going to change all the employees from, let's say, here's an example for normal layman's listening, from Android phones to forced iPhones. Okay, now I'm gonna say that again. Everyone overnight will go from Androids to iPhones. How disruptive do you think that'll be for a hospital, right? So, and that's why you have to make sure -1, 2 years before you make that transition, you train, you let them understand you're gonna have to see less patients for now until you get used to the software, right? And now how we're gonna make up for that difference financially. So there's a whole lot going on when it comes to this adoption of technology and what we can do. So peopleware, focusing on the people, process, and tech. What happens is folks will focus on the processes and the tech, And they forget some of the people in here could have been here 30 years. They could have been doing this one job 30 years. Never heard of Epic, never heard of Cerner, never heard of Allscripts, eClinicalWorks, Android, iPhones, right? So tech, and we're dealing with 5 and 6 generations now. So I think I would just say I would really want a health system to be really careful. AI is a win. You don't treat it like a normal technology. Be focused with it, understand what it can do, learn your use cases before you just start throwing it out to like keys laying all over a parking lot, and now you start picking them up, looking to see which lock they go into. That's what has happened over the world, the US, when it comes to technology. There's just been all this tech dumped. And now it's up to the users to figure out what's the best way. And I think that's where I think opportunities to go off the rail could occur with AI. Just one of my many points.
So go ahead, Brad.
I was going to say it's a huge cultural shift, right?
Right. Yeah, that's it. It's a cultural shift.
Yep.
Yeah, if you ever used an AI model, right? Just talking to it or trying to get information from it, it's very odd, one. And so how do you disperse that level of technology across this many various diverse humans, multidisciplinary teams and all that, right? So
But I think what I heard from you there, though, is that starting from the point of wins is a big difference, because the change management is a lot easier when the people that you're changing, when they have a very positive reason to embrace.
absolutely.
Whereas with EHRs, it was so theoretical. It was like, well, one patient in 100 will be saved from an error with this, and it's like, well, that's a pretty abstract benefit.
That's it. That's it.
Costs.
It's the with them. You gotta say, what's in it for me? Especially in 2024, doctors feel, nurses feel that they have been a bit abandoned by technology, and this is just the vibe, right? I'm a consultant. I've been all over this USA, a lot of different companies, interviewed a lot of docs, and now strategically advised for VC startups, and I've got a really close relationship with some of the big vendors. So these are really important that we understand what is the vibe. If we release this, will they come? Like Field of Dreams. And typically it doesn't work like Field of Dreams. If you build it, you just built it. Okay, there's no mysterious baseball players walking out the corn, Joel, and so because they're seeing patients. So I don't know. That's my thought. I don't know.
So starting to transition a little more into the actual AI technologies, then I'd like to hear from Bob, from you. You've been building AI tools in healthcare for almost 10 years now. Can you tell us just briefly, just so we understand what about Veda's technology, and maybe kind of walk us through where you were before, before these LLMs, and how that's changed, what has changed in your perception of what could be adopted, what's possible with these new LLM technologies?
Sure. Thanks, Joel, and thanks for having me on the panel. One thing that's kind of interesting is I haven't been in the field of healthcare for as long as my colleagues here on the panel, so I tend to see things from a slightly different angle. Veda is a company that uses AI to help reduce the administrative cost and burden on doctors. So this is something that really echoes what David was talking about earlier, which was the dream of technology to help make their lives easier. In the early days, it seemed like maybe the jobs got a little bit harder with all the additional typing and keying that had to happen. At Veda, we're focused on using AI to reduce the amount of interactions related to billing, contracting, and administrative setup of doctors with their relationships with payers, to help make it faster so that updates to directories show up quicker, and they're more accurate, and they involve fewer mandatory steps. When I zoom out a little bit and look at the new opportunity with AI and large language models, I can really resonate with what you folks just mentioned about the cultural shift that's going to have to take place. And in order to do it well, really understand the strengths and weaknesses of the kind of technology that we have in front of us, because it is a huge opportunity. But what's kind of interesting about what's going on is if you have a very large and deep model that predicts weather forecasting by location, you wouldn't necessarily call it AI, you call it a model or a prediction engine. If you had a very deep model that through large data sets predicts traffic patterns or maybe predicts purchasing behaviors, you wouldn't necessarily call those AI, you call those trained models and forecasting systems. But once you've got a forecasting system that predicts the next word based on a sequence of words, now it's AI. Humans, of course, communicate with language. We associate language with intelligence. So this particular application of these kind of large models to predict the next token from a sequence of tokens is breathtaking what it can do. But we need to help it succeed in that it is still going to, because it's matching patterns, it's still going to have some challenges in some narrow areas. And at Veda, we help companies adopt AI into their workflows. And so adoption and successful adoption is a big part of the game. My advice there for everyone listening and for the folks on the panel is to help all of our stakeholders really have a measurement-based mindset. Understand where you're starting in your processes and understand where this technology can get you, because it can get you very far. And sometimes, what's kind of interesting is a human-driven process gets the benefit of the doubt, even if it's inefficient. That's where the phrase, well, I'm only human, that's where it comes from. It's, I made a mistake, but I'm just a human, so what are we going to do about it? Machines do not get that luxury. And so when it makes a mistake, it makes headline news. Like you saw a entertaining example about one of the large mainstream models not understanding which number is larger, 9.9 or 9.11. That kind of thing happens because it doesn't really understand numbers, but it does know the most likely thing to say next. And so that isn't necessarily a reason to not adopt it. It's just a reason to understand where to use it. And so adoption and sort of safe and transparent adoption is the way that we take this technology to really benefit society.
So David, one of the things I've seen in working with these technologies that Bob is kind of alluding to is that you could have an area where a human is wrong on some particular task 20% of the time. Mm-hmm. And then you get a technology system, maybe is wrong only 5% of the time. So 1/4 of the error rate. And yet what you hear often is, well, that's not acceptable. It's gotta be 100% accurate or 99.99. So do you think that what Bob's proposing, where we sort of teach everyone into like, oh, this is what the numbers say and we can measure it and it's better, like is that realistic? Or are we going to need to, before we deploy these systems in clinical settings, are we going to need to get to 99.99 because they're not human, so that we have higher expectations?
All right, I'm gonna go off script here.
That's what we're here for. That's great.
I know, right? Yeah, because I've been doing this too long, man. Sometimes you see so many things, and I just feel like there are some parts of healthcare, I tell you, that is just hyper regulated. Like, calm down, especially docs, like practicing docs. How many risks we take every day, every patient, right? And so we laugh when we look at a company and they can't take a collective risk, right? And it's like, what? It's like we are risking our license every day when this lady says, well, I think that's the medicine that gave me this or that. You're like, we're thinking this is the best medicine for you. I can't quite trust that your memory of that white pill. We do this every day, like Cirque du Soleil, right? And so it's always laughable when we see institutions or entities or groups that have really hard data that says like, wow, 90% of the time this works this way. We're like, whoa, 90% of the time? I'll take that 90 and I'll augment it with my knowledge, and I can make that now 150, right? Meaning that's going to work. But because our legal litigious systems are so intense and we're so afraid of them as docs, we will have to cover our ass sometimes. Like, we're like, ugh. And what we know right now is that we feel a lot of the physicians that are practicing right now, frontline guy, that's what I'm talking about right now, so you get a vibe. They are getting overtech by the patients. The patients are whipping them all over the court when it comes to technology. Patients on ChatGPT at home, the free version, or Gemini, or Llama, or Mistral, or whatever you want to call them Bob. They're getting information that shoulder hurt. What do you think it is? It goes down to my pinky finger. And next thing you know, they have a differential diagnosis from a really smart doctor that may have gotten misinformation though, because the computer didn't know the other question to ask to isolate that, what's really going on. You understand? And so docs are getting these My Chart messages for free, by the way. No one's paying for them. After hours, just want to make sure you're there. I got to represent my docs, right? So they're getting all these free messages from patients about things going on in their life that they're not even sure if this patient is still their patient or their insurance is over and going on, right? So it's a lot going on in here, right? So when you say that, I just want to make sure that everyone understands that part and just the lack of attention that the bombardment of technology that patients are giving docs. And for us, we're kind of on this side, like we're hoping that our health system will turn on a tool where instead of talking like this, I can sit my iPhone right here and it's picking up the conversation. And when the exam is over, the full note is already done, literally within 20 seconds. And health systems right now are still stuck trying to figure out, well, we're not sure if this is good or bad, it may hurt someone and this and that. So this is what doctors are witnessing, right? Every day. And they're burning out. We have the highest suicide rate, right? And so, and also compensation's going down. And so just the professionalism, it's called burnout in general. So doctors are getting burned out, right? Multiple reasons, not just the HR, right? And so, but what we're seeing is like there's a hesitancy of sometimes of healthcare system to be more aggressive to help us, because there's some other things that they may be concerned about from a legal perspective, which we all understand. But I just want to make sure that that's what you're seeing out there, and maybe the hesitancy from the Aveda, right? Startups that are trying to sell in these health systems, right? They think everyone's AI washing things. So they have a whole line of folks that are in line to sell healthcare system things, right? Because of a lot of the rules and governance that needs to go into place for this big unknown thing called Gen AI. And so just my hot take. Sorry about that. But I want to make sure kind of explaining that, and I hope that makes sense.
So Brad, maybe shifting a little bit to your side, which I think in some ways you have a little bit of a more of a free reign to experiment than sometimes some of the frontline areas do. Maybe you can talk to what your experience has been and what you've been able to adopt, and talk about some of the cool things you've been able to do on the research side at MCW, or what you've seen elsewhere.
So yeah, we've been working on a number of projects over the last year plus in the Gen AI space. Just to kind of reflect on what has been said by both Bob and David, I think the key here is that we need a human in the middle to evaluate whether those textual relations that David, you said you're capturing on your iPhone and having that being put into the medical record. I think the human needs to review that beforehand to make sure that the health system is comfortable with what's being put into the documentation for that patient. And I think that also kind of helps to solve part of the issue around the 5% of the time a Gen AI solution is going to come up with a bad answer, and it's going to be a horrible outcome for that. A human in the middle, at least in the near term, is going to be extremely important. I think longer term, as we kind of evolve in this space, we will become more comfortable with it. I think there's a lack of comfort with it today, or lack of adoption for it today. Yeah, we're doing a lot of different things. So we cover things on the research side as well as kind of on the operational side, not from a physician's perspective or a patient's perspective, but operational for the health system. We've got a couple of projects underway right now where we're using Gen AI to help us fill out the NISQIP or the surgical quality improvement process. It's a registry that we need to support. And it required historically a lot of manual intervention to curate that registry. So using Gen AI to help us improve these registry submissions. We're doing the same thing with the AHA Get With The Guidelines, and we're also looking at the Nature Tumor Registry to help us accelerate those things, because some of these registries or some of the forms being submitted to the federal government or even state agencies are quite delayed because it's significant manual curation to help accelerate those things. We think we can accelerate those submissions and the accuracy of those submissions significantly, and we're having some good success early on with that. On the kind of the research side, we're also in the process of creating a system which will evaluate all patients coming in the door for clinical trials. Initial focus has been in the cancer space because these are potentially end-of-life situations where we want to accelerate therapies for these patients and hopefully extend their lives. So we are currently launched a program in July. So we're very early, and we're looking at kind of the impacts and carefully capturing metrics. So Bob, back to your metrics capturing to understand what is being successful, and where do we need to tweak the model, or where do we need to tweak systems to help us get there, and to gauge the effectiveness of that. So we've got several different things that we're working on, kind of from the operations of the health system as well as clinical research, specifically in patient trial matching, if you will. And it's really a matter of balancing skills and timing and capital investment, and taking a holistic view across the whole health system, both on the research side as well as the care delivery within the health system. I'm from the academic medicine side, so that's why I keep going to the research piece of this. But we've got a number of different projects. We're doing kind of a mixture of building things in-house, as well as tapping into experts in the field, people like Bob, who are experts in large language models and can bring to bear some things that are outside of the health system. So we're looking at those partnerships as being crucial to help us succeed. And then we know that Epic, our good friend 70 miles to the west of me, is also implementing various Gen AI solutions within the medical record system itself to help facilitate the physicians as well as to help facilitate patients. So it's a kind of a best of breed look at what is taking place in the market. And we're doing a variety of different things in that space.
Great. And in terms of when the stuff you're building in-house, are you hiring, something some of our audience might be interested in is just sort of talent and how that works around AI. Is your existing team learning the new tools and how to build these models and work with them, or have you hired in people who are already knowledgeable or experts on large language models and how to use them?
It's a mixture. We have some people that have been cross-training to get their skills up to speed. We have some people that have been dabbling in large language models for a couple of years now, so they bring things to bear very well to the organization. But then we are also hiring onto our staff as well. And we recently stood up a data science institute that's going to be focused on artificial intelligence at large. So not just Gen AI, but artificial intelligence that might be predictive modeling. It might be other types of logistic regression applications, et cetera. So we're looking at expanding our workforce. We're partnering with our local educational institutions, the higher ed institutions, and creating training programs utilizing privacy preserving data within our health system. And we're trying to encourage those to get into the biomedical artificial intelligence space, because biomedical is really a unique space, and having that domain expertise is really critical. If we think about artificial intelligence or data science as a whole, it's a combination of or amalgamation of skill sets to include data engineering and software engineering and domain expertise and statistics. So we need an amalgamation of a variety of skill sets to help accelerate those kind of discoveries and move things forward.
Hey, Bradley, question for you. Just
yeah.
But you said biomedical. When you say that, like all the hospitals I've worked in, whenever you hear the word biomed, it's another department. It's outside of IT. They just deal with smart pumps and stuff like that. And that's all we know about it. What is it? As a doc, I'll put my doc hat on, right? So
Right.
tell
Yeah,
me,
yeah. So
yeah, what do you mean?
yeah, it's so when I think of biomed in this case, I'm thinking about my biomedical informatics. So it's using
Informatics.
real world data to solve to identify problems and to create solutions.
Okay, awesome. Just want to make sure.
Yeah, you bet.
Healthcare tends to take definitions and do what we want to with them. So I'm glad
Yep.
Bob's on here because Bob's bringing an external perspective. That's always great. I love when anyone external coming to healthcare. I like, oh yes, let me tell you about it first because I know you're going to come up with good ideas that's going to help us, right? So yeah.
I learn a lot every day absorbing in the health field. Yeah.
So David, what about on the clinical side? Have you seen any? We've sort of talked theoretical. What could work? What could be the big benefits? Are you seeing anything in your work as an advisor that any use cases yet that are actually making a positive impact with artificial intelligence for doctors or whether that's patient care or even administrators? On the delivery side yet, or are we still kind of theoretical at this point?
No, I think we're seeing some early wins, honestly, just on the just for in-basket, for example. A lot of folks don't know in-basket is. In-basket, what I was mentioning earlier, right? All those messages that are coming for free, right? Okay, now we're able to actually place a bot between the patient sending Dr. Butler a message at 12 a.m., right? About a fever of her baby, right? And we're able to catch that and say, whoa, this is for fever and it's 12 a.m. and Dr. Butler's not even here. Let's go ahead and send something that we know is solid enough that's going to be 100%, to say, we recommend you contact the ER. Like, all right, like that's an easy, right? It's almost like not even AI. But the next level is when a patient emails me, hey, Dr. Butler, you started me on Synthroid 0.5 milligrams 4 weeks ago. I still feel a little sluggish. You wanted me to contact you back for possible another TSH level. Yeah, right. This is where this is what comes, right? And this is only one of the 4 medicines that the lady's on, okay, or the person's on. So that alone comes in. We now can Epic, inside of Epic, it's called ART, automated response technology or some name Epic gives it, whatever. It's just basically LLM, that a trained LLM, right, that grabs the message and drafts a response for the doctor based on the patient's information. Right? Now, how much time does that save Dave Butler? A lot. Because when she says, Dr. Butler, that medicine, I'm trying to first figure out who is this patient? Why did I give her the medicine? And why did I order the labs? Because it's been 1 of 25 and this was 2 weeks ago. You get it? So within a minute, it can summarize, it'll give me a one line of like, this is this patient, this is what you saw her for, this is the medication. And then one click, it can jump to the note where it's pulling it from. You got it? Okay. I'm gonna say that again. It's like an email that comes 5 weeks later from a meeting that you forgot you had, right? And all of a sudden it summarizes for you right at the top. Come on, man. I mean, if nothing else, this should make docs feel like we care. And that's what I'll take. Whether the data shows it's helping or not, I don't care right now. It does show it's helping them, right? But that's the type of things that we got to get used to doing, is making technology so when it happens, it feels good and it feels like, this is what it's supposed to be. Technology is supposed to help us, right? And so that's kind of what I see happening, and some positive stuff there. Also, just with diagnostics, you got early detection of disease. I was a chief medical officer at an AI company startup, where basically you give us your CBC, which is like 15 parameters from your blood that we just checked. You show us that from a year ago, we're going to let you know what % higher chance you got of colon cancer, right? Or something down there in your lower bowel, And so those are some things that we could not do this, right? I was watching a video the other night, a BBC Earth, and I think it was night. And then I watched behind the scenes how they shoot at night and all the new technology that allows us to see night stuff, right? I'm a nature buff. And they're like seeing this big orangutan just going through the trees at night, almost as if it's day. And the producers, the film guys, not scientists who study orangutans, the film guys are saying that the scientists that study orangutans they never knew orangutans behaved this way. That blew my mind, because here's the deal. Technology overnight has now revealed something that's been blinded from us for years, right? So I think that's how my brain works when I see things like this, and then extrapolate out. You got Brad on the back end, right? No, you got Bob in the middle there. Make sure all the administrative chaos is occurring, and that's helping out automated healthcare. You got Butler on the front end, the clinical guy. Then you got Bradley over here looking at proteomics, genomics, and all this other stuff that's just going to be crazy cool, right? That's a direct. So I think together, as each one of these things line up, we're going to see really cool stuff. That's just hard to see what that's going to be in 1 to 2 years. I don't know. That's just my hot take, and I pontificate all day, Joe.
Great. That's what you're here for. Bob, on the just for your perspective on the sort of grading technology side, do you envision these AI technologies kind of gradually evolving? Is it going to be more about, well, we have these models now, we just got to find all these places we can slowly kind of find the use cases, more things like what David's talking about? Or are there big moments of change still ahead? Are there going to be big, large sort of step functions still, over where stuff we thought was important now is going to be, not important because it's so much easier to do X, Y, Z? What do you see in the next 5-10 years?
Yeah. Thank you, Joel. My prediction is that for most corporations who are sort of on the hook for solving a problem or reducing a cost at the end of the day, you're going to see a lot of traction behind the scenes on a lot of narrow models. There's a story that I think of once in a while. A lot of years ago, I was at the EAA Air Show in Wisconsin, and there was a demonstration of the Ford GT supercar, and it was actually racing an airplane, and it blew the socks off this airplane in terms of speed in like a short track, right? And it was one of the coolest things that I saw. It drew a lot of attention to Ford. Ford, though, doesn't make a lot of revenue off the Ford GT supercar. They make it off of things like the Ford F-150. But the supercar draws a lot of attention to the field, a lot of attention to the brand. And I think what we're seeing is a lot of these super mega models that can talk about anything do draw a lot of attention to the field, which can be good, and a lot of really fascinating capabilities. But if you're going to use it in a hardened way on a mission critical system with the right privacy settings and security requirements, you're probably fine tuning a narrow model in-house. And so it's got this sort of duality of worlds, the sort of giant flagship model for that purpose, of which we're still trying to figure out exactly what. But then folks like myself and folks like Bradley here are hiring folks to adopt the learnings and technology, but in a more controlled environment. And I think behind the scenes, you'll have a typical corporation that isn't powered by one mega model, or powered by 36 narrow models. And that's kind of what I think our future is.
Great. And what about training data? This is kind of, Bob, for you or Brad, I think is that's one of the big things that is, maybe differentiates different models, maybe doesn't. We don't, there's that's one of the things that's a little more secretive by the companies that are putting these out. Even, Meta is supposedly their llama models are open source, but their training data is not. So I wonder if either of you you've done training of these models can reflect on, is that going to be a big barrier? Is that like, how much is that going to be a limiting factor? Are there going to have to be changes in how healthcare handles data in order to unlock the potential of these models with using training data?
I'd be happy to kick this one off if you don't mind, and then I'll be brief in the interest of time. Training data is big, and I think over time it's going to be one of the biggest differentiating factors. You can think of it as, in the last several decades, we've been digitizing since David mentioned his residency, when the digitization happened. We've been digitizing a lot of human created assets for years and years and years. All of that is a big dry powder viable collection of data that is now being used for training data. So we have the most quality human collected training data today than we've ever had. And what is going to be tricky in the future is that now some of the content in the world will start to be AI generated. And as that starts to replace some fraction of the human generated content, you'll never again have this much rich human generated content in the history of AI potentially. And so it's something to keep an eye on. And when it comes to individual applications, fine tuning requires your own training data. So for sure, each corporation or entity that's making models like that is going to think very protectively, very seriously about how they collect, maintain, quality control, and grow their own collection training data set. Because the algorithms are open source, but it's your training data that makes a killer model.
Right. Brad, I'm sure you have lots of reflections there. I'd love to hear it.
Yeah, I do. So as I reflected earlier, we've been working on a clinical trial matching program for our cancer patients initially. And so what that means is that we needed to take one of these foundational models, the Llama. We ended up using Llama in our case, and training it on our own data. But we have some concerns in that space. So there is potential for having HIPAA protected information buried within the clinical documentation that the docs are generating for that patient record. And so we had to take a very close look at how we did that training and making sure that we had privacy preserving techniques and de-identification techniques around that data to protect our patients at the end of the day. So those techniques are extremely important to taking that clinical information and training that within one of these larger foundational models. So I agree with you, and you actually stole my thunder from something I planned on talking about in the near future here. With regards to foundational models, got us off of the ground, but I am a firm believer that we'll be looking at small language models. These highly tuned, specifically targeted models that are trained on very targeted information to solve a problem, and that can be daisy chained together to have an application associated with it. So I do think that we're heading down that space. But it was extremely important to make sure that we trained our clinical trial matching application on our patients' data, because the way David, you document is probably different than the way some of our doctors document here. There could be health system differences, the way things are being captured. It could be the individual doc, the way they're capturing things. So it was really important for us to capture how did we document on our patients and how do we train the model on that data as opposed to some other outside source that we don't know where it came from, this open source environment, if you will.
Great. Well, we've just got a couple, just our last question here. And I think I was going to do a bit of a round robin in terms of prediction. So sort of 5 to 10 years, where are things going to be? But I think Bob and Brad have both somewhat already answered that question, which is that we're going to get more and more fine grained with these sort of killer use cases for specific things with narrow models. I think I think that reflects how you guys would have both answered that question. So maybe David, let me end with you and kind of on the user end of things, or maybe as an advisor to systems end of things. What do you think is going to be in the medium term here, between 5 and 10 years, not 20 years in the future and not next year, but how big can the people watching this panel, how much change should they expect when going to the doctor or talking to their friend who's a doctor in 8 years? How different will the delivery side of things be because of AI?
1 minute and set a timer on this. I'll keep talking. So I don't know.
You got 2 minutes.
2 minutes. I'll take 2. It just cut me off. It's like whatever. Pull it. Hollow guy come out. Pull me off. So I don't know. I think it's going to be. I don't know. I see a lot of opportunity, and this is honestly one of those places in healthcare that I've been waiting for since 03 when I joined Geiser Health System, and I saw how labor intense managing an EHR while a patient's talking to you, and I'm trying to pay attention and order and do all this other stuff together. It's really tough stuff, right? And it causes burnout. So I think that once just generative AI from just natural language, picking up what the patient's saying, what the doctor's saying, is huge. That's huge. That's one. Big burden lifted, right? Efficiency locked, right? Unlocked. Next one is going to be the orders. Like the next thing we got to do is like, I'll say, hey, Joel, I'll tell you what I'm going to do, man. I'm going to start you on maybe this cholesterol lowering drug called lovastatin. We'll start at 10 milligrams, whatever. When I say that, it's going to be queued up to order. Why not? It's ones and zeros, right? And so as a doctor, I look at a human body and I see something that we didn't create. God or a divine being or evolution, whatever Bob you want to call it, right? And this is what we deal with every day. We practice medicine. We're practicing this. And so I always tell people, and I'll wrap up with it, some of the toughest patients have been some of my toughest patients over the years have been very spiritual patients because they, quote, pray too much and don't come to me also. Like you can, say, pray but row away from the rocks, the old Indian proverb, right? And so that's one. I'm a very spiritual person as well. Two, engineers and IT. Boy, I tell you, IT, when they come to me as a doc, it's very difficult because they don't quite understand fully, like, this medicine may work for your twin brother, but that medicine doesn't work for you. They cannot figure out how the hell that happened because in IT, ones and zeros is the rule, right? And engineers the same. If this side of the equation equals this side of the equation, that rocket's going wherever the hell it's going. You're astrophysicist, right, Bob? Right? I mean, right? Isn't that how you guys work? You work models to make sure with laws of real gravity and things, right? And so I think in medicine, we've had to dumb down all of the cool stuff that we learn and can do and do all this other stuff to this EHR, which is black and white, and everything else in healthcare is 126 shades of gray, 256 shades of gray, right? And so where I see this going is that the doctor that was responsible for like preventative medicine, chronic disease, medication refills, test results, even all the stuff that we have to do, what you're going to see is hopefully we're going to parse out each one of those, right? Where refills should be automated. Like certain refills, like, don't call me, because we're at a place in science in the world now where that's how it's going to be. Okay. Also, certain things such as, like, for example, these large language models have passed the USMLE Step 3, the bar, a sommelier's exam. Okay. I don't know how they do it, but what I do know, if that is true, and healthcare costs are ridiculous right now, access is unheard of right now, I think where this thing is going to be moving to real quickly is to those poor patients that need healthcare. And they will take a misdiagnosis from ChatGPT 2.0 versus a no diagnosis from anyone else they can get to, or Google University, get it? And so I've looked at that. My mother's a nurse, 40 years. My family, small town Texas, kind of poor. My family has called her for years as their doctor. Hey, Stella, my stomach's hurt. What do you recommend? She's a nursing home nurse, 40 years. She knows the cubitus ulcers. She knows nutrition, but that's about kind of where they focus there, right? And so that's why I feel like the consumer side may have a little bit more play here. And for consumers that are willing to pay, Joel, or Bob or Bradley, would you be willing to pay $25 for a chest x-ray at a Walmart where it could be 90% right? Right? You know what I'm saying? Like, the positive predictive, as long as you know the data, right? Would you be willing to do that for $25 versus going to ED, get a chest x-ray, and God knows how much you're going to get billed for? I don't know the answer to this. I'm just waxing philosophical here, Joel.
Yeah, I think that's a very thought-provoking way to.
I think something's in here that's disruptive, that is really hard to tell right now because there's so many moving parts, but the patient's going to win.
Yeah. All right. Well, thanks everyone. This has been a great conversation. I really appreciate you all taking the time to participate in this panel, and we'll look forward to hearing more on this topic, hopefully in the future. Thank you all, and have a great one.
Thank you. Take care.